Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and welcome to yet another ICU Primary Snippet. So, Maddie, this snippet is about the pharmacology of GTN. Can you tell us about GTN?
Yeah. So as for all the pharmacology questions, divided it into the indications, pharmacokinetics and pharmacodynamics. So GTN is an organic nitrate and a potent vasodilator, but has greater effect on veins compared to arteries. In terms of the indications, the main things we use GTN for in acute myocardial infarctions, which is associated with congestive cardiac failure, in left heart failure associated with pulmonary edema, treatment of angina, so acute episodes of angina or prevention of chronic stable angina, hypertensive emergencies, control of blood pressure and aortic dissections, but this is after beta blockade, perioperative hypertension, especially during cardiovascular procedures, and topically as in for anal fissures or relief post-hemorrhoidectomy. In terms of the pharmaceutics, there's a variety of pharma formulations available. So it depends on what route you're using, but there's for the infusions, there's a concentrated injection available, which is 50 milligrams in 10 mils or 50 mils, but this requires dilution with saline or 5% glucose prior to administration. There are transdermal patches available, which come in 5 milligram, 10 milligram, or 15 milligram per 24 hours. There's a sublingual spray or a sublingual tablet. The sublingual spray is a pump which has 400 micrograms a dose, and the tablet is 300 micrograms a dose. And then there's a topical ointment, which is a 0.2% strength in a 30-gram tube. In terms of the pharmacokinetics, we can divide it into the administration, absorption, distribution, metabolism, and elimination. So in terms of the administration, as I've mentioned before from the pharmaceutics, you do have a variety of routes, so sublingual, transdermal, topically, which is rectal or intravenously. You might see that if given intravenously, it's given in glass and non-PVC giving sets as it's absorbed by PVC. And for when we use it for the GTN patches, it needs to be applied to clean, dry skin, and this is generally on the chest or upper arms. The dose depends on the route and the indication. So if you look at the show notes, there's different doses depending on which type of administration route you're using and for what effect. In terms of the absorption, it is well absorbed from the GIT, but it has less than 10% bioavailability because of extensive first-pass metabolism. Sublingually, this bioavailability improves to about 40% because it bypasses first-pass metabolism, and it has an onset of 1 to 3 minutes and a duration of action of 15 to 30 minutes. It's also well absorbed transdermally, and the plasma concentrations of nitroglycerin reach a plateau within 2 hours, which is maintained over the whole application period of the patch and fall rapidly after you do remove the patch. And it also has a rapid onset and offset when given intravenously, which means it's easy to titrate. So the therapeutic effect is within 1 to 2 minutes with a duration of action of 3 to 5 minutes after a single dose. In terms of the distribution, it has a volume of distribution of 3 litres per kilo with 60% bound to plasma proteins. And it's 2 of the metabolites, 1,3-glycerol dinitrite and 1,2-glycerol dinitrate, are 60% protein bound and 30% protein bound respectively, and do have some mild vasodilatory actions. In terms of metabolism, it undergoes hydrolysis in the plasma and is rapidly hydrolyzed in the liver by glutathione organic nitrate reductase, and this is to the dinitrates and the mononitrate. The dinitrates, as I mentioned, do have a very weak vasodilator effect, but the mononitrates are inactive, and glycerol mononitrate is the principal metabolite which is inactive. We also know that it's metabolized by sulfhydryl-dependent enzymatic processes in the erythrocytes and within the vascular cell walls, and has a half-life of 1 to 4 minutes intravenously and less than 5 minutes sublingually. It's eliminated mainly by metabolism and excreted in the urine, and the clearance is 1 litre per kilo per minute after IV administration and 21.9 litres a minute after a sublingual dose. In terms of the pharmacodynamics, the mechanism of action is interesting. GTN is like a prodrug, so it requires enzymatic activation intracellularly. This releases free nitrites, which is then converted to nitric oxide. The nitric oxide activates guanylyl cyclase, which increases the levels of cyclic GMP. And this dephosphorylates myosin light chains, which decreases intracellular calcium. And we know that intracellular calcium is important for smooth muscle contraction. So decreased intracellular calcium causes smooth muscle relaxation, which causes dilatation of the arteries and veins. But as I mentioned, the veins are dilated preferentially. When we think about the therapeutic effects, so in lower doses, it's venodilation, and this decreases venous return, which decreases preload and decreases the ventricular wall stress, which as in turn decreases myocardial oxygen demand and improves subendocardial blood flow, which will decrease symptoms of angina and the cardiac workload. In higher doses, there's also arterial dilatation, which decreases systemic vascular resistance and afterload, causing a decreased blood pressure and decreased myocardial oxygen demand. It also causes a coronary artery vasodilatation and reduces coronary artery spasm, and it decreases LV wall tension and decreases afterload, which all decreases myocardial oxygen demand while increasing myocardial blood flow. So it gives you a more favourable myocardial demand to supply ratio. In terms of the adverse effects, these are mainly from its vasodilatory actions. So it can cause hypotension and it can activate the baroreceptor reflex, which can cause tachycardia, which might reduce or obliterate the beneficial effects of this oxygen supply demand ratio that we just talked about. It can cause postural hypotension and cutaneous flushing and headaches due to cerebral vasodilatation, raised ICPs and vertigo. It can also cause nausea, vomiting, rash, and rarely methemoglobinemia. And we know that tachyphylaxis does occur with frequent or prolonged dosing, and this risk can be reduced by using the smallest effective dose at a reduced frequency. The tachyphylaxis is thought to be due to a depletion of the tissue sulfhydryl groups or scavenging of nitric oxide, which then inhibits guanylyl cyclase. And this is also part of the reason that we put the GTN patches on for like 12 to 14 hours and then take them off for 8 to 12 hours.
Thanks, Maddie. That's great. So that's the end of our today's snippet. We'll be back in week's time with another snippet. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.